Hello, everybody. Good morning, good afternoon, good night for those of you that are across the continent. Um, I'm Patty Musolino. I'm a neurologist and an intensivist, and I practice in Boston in Mass General. And I am going to be doing the presentation today. And this opportunity to get together came out of that one of the studies that we've been doing with several colleagues across town with Boston Children's, Dr. Smith at the Martino Center, and with Dr. Milowicz in Houston, just came out in neurology, and we wanted to make sure that we take that opportunity to share it with you, but also to put it in context of maybe how you need to learn about your own disease or your child's disease to really make the best out of what we learn and improve the quality of life, the interventions, the management. So I'm gonna pass it on to Sam. She's gonna give us a little bit of guidance on how we hope to run this session. We really want to have questions and interactions, and this is a moment to get together as a community in a virtual way. So take advantage, and we also letting you know that this is being recorded. Is that correct, Daniel? Yeah, okay. It's already being recorded. And I will introduce some of the authors and the people that made this happen as I go into the presentation. Sam, she's one of the first authors with Arne Lauer, and that is somewhere, if you put the gallery view, you can see. And Arne is in Frankfurt at the moment. Sam, where are you? Virginia? Okay. And Sam is currently in medical school, and Dr. Lauer is already graduating from neuroradiology. He was a postdoc with us many years ago, but now he's a consultant. So, Sam, do you want to give us a little bit of a run through how we can do this to start?
Yeah. So first of all, welcome everyone. It's good to see some familiar faces. So what we're going to do is we're going to do a presentation. And so if you have any questions, feel free to put them in the chat or and then at the end, what we'll do is we'll have a Q&A, and then I'll call on you to unmute yourself and you can ask your question. If you feel more comfortable just sending your question directly to me, then I'm happy to ask it for you in that way as well. There's also in the chat function, you'll see at the bottom of the bar, there's a little box that says chat, and you can open that up, and there's a drop down that you can send the message to everyone and then or to any particular user. And so this is a great opportunity for you all to network with each other as well. So feel free to chat with one another. If you have any questions, you can send the questions directly to me for the Q&A or just about anything in general. Otherwise, please keep yourself muted throughout the presentation. Just with the bandwidth, it'll be a lot easier if you don't have a ton of people talking over each other. And so, yeah, that's basically it.
Excellent. Thank you so much. I'm gonna start sharing my screen. You guys let me know if you can see it. Or not. Yeah, you guys can see the presentation? Okay, and now? Okay, good. So first of all, thank you for your interest. I do want to say, in case that there is someone in the call, because we've been using a platform that we have with the MGH pediatric stroke team, and this is run by a parent advisory board, and it's a resource for all of you. There are different aspects of recovery and how to support the development of a kid that has cerebrovascular disease and stroke. But in case there is anyone in this call that does not have a child affected by ACTA2, please do not take what we're talking about here as something applicable to your child if you haven't been diagnosed with ACTA2. And that's important in case anyone is participating as something that they want to also be part of. So we wanted to share these updates on what we learned about how the cerebrovascular disease happens in ACTA2 and what happens over time. So as you know, Dr. Milowicz led the efforts of diagnosing the gene, the mechanisms. She's the world leader, the godmother of the disease. It's pretty much named after her. And from there, we've been collaborating since that natural history study in 2018. And this time we expanded that study to just look very carefully at how the brain was affected in these patients. So the authors that make this happen, the lead authors, as I told you, were Arne, and Samantha, who you have in there. And then there is a lot of people that make the database possible, and you being part of these efforts and these studies. So you probably have met either Ellen Regalado or Sam Speroni, who were collecting the information to make this happen. And then you are a lot of other names that you don't see, like Jayshri and Jay and Millon, who have been working on the software and all the technical aspects that make this research possible. And they're primarily in Germany and in Boston at the moment. Edward Smith is the neurosurgeon at Boston Children's that has a lot of experience in genetic vasculopathies and moya-moya disease. And then Dr. Caruso is the neuroradiologist, the chief of pediatric neuroradiology here at MGH, and has helped a lot curating the data and making the calls of what we were seeing and guiding what we're going to show. Very important disclosure here. What we are going to be saying is not a recommendation to you, and it's not medical advice. You rely on your primary team. And if they have any questions, please have them contact us. We are pretty much in contact with most of your primary teams already, and that works really well. But do not take this as I need to be doing that. Discuss them with your primary team. And then we ask everybody to participate voluntarily, and you guys have signed disclosure, so you know what we are doing. These are my financial disclosures, and this is something that the hospital always asks us to do. I am involved in gene therapy for other diseases and small molecules to treat genetic vascular disorders that cause inflammation in the brain, and blood-brain barrier disruption, and small vessel and large vessel disease. And there is an effort that happens with a lot of industry partnerships. My lab, the bench where the animal models and the cells, and we are trying to develop these therapies, is funded and has been funded by NIH, the National Institute of Health, the Neurological Disorders Division, and a lot of help from philanthropy to start the projects, including the ACTA2 by the Be Heard Award and the Dulles Families Research Fund, which is an Australian family patient of ours. And MGH, Department of Neurology, has been supporting a lot of these efforts and hosting, as you know, the first meeting that we had, and to coming soon, the next meeting, the second meeting is being organized at the moment, so you'll hear more about that. So where are we? And for those of you that haven't been in Boston, this is Mass General Hospital. We are a very large hospital with adult, more than 1,000 beds, and a smaller pediatric hospital inside it. And we are pretty much like 1.5 miles from Boston Children's Hospital, where we also have a lot of collaborations also in rare diseases and gene therapy. And this gives us the opportunity to also see patients from before they're being born all the way to the end of life, which is an excellent opportunity for these genetic vasculopathies that are so complex. So what do we want to accomplish today? And I want to be mindful of time. So Daniel and Sam, you really had to cut me off if I've been speaking for more than 35 minutes in a row. So ideally, we want to cover a lot of basic stuff, and I bet that a lot of you are experts on this, and if there are clinicians, please forgive me for going over very neurology and anatomy 101, but we wanted to set the stage so when we talk about data and what we found, everybody has somewhere to put it on, so it stays in a different way, and also you can use it, and it's not just anecdotal stuff. Oh, there are more strokes after here and there and things like that. And then try to go very granular into the ACTA2 disease and how the small vessels and large vessels are affected. And we do want to discuss monitoring preventive strategies and some of the rehabilitation strategies. And in the treatments, we are going to be talking about complications and things that we are seeing being done. And again, with a lot of humbling ignorance of what really is the best care, because it has to be customized to the kid or the person's condition and all organs taken in mind. And then we want to give at least 20 minutes for Q&A, so questions and answers for you guys. We're planning to end at 1:30, but for those of you that want to stay a little bit longer, there is also the possibility of staying for another 15-20 minutes. So everything started in this community. Many of you in the call have been in Boston in person, and many of you have been online with our Facebook remote transmission of the meeting. And this was in 2019 in May, and it was organized by a group of parents that got together in one of the Love for Libby galas in New York and said, hey, we need to get together to advance knowledge, advocacy for the disease and the treatments, and get the researchers together. So this led to the formation of an alliance, a foundation for the patients' families. But this meeting involved already, as you can see, a lot of different experts coming from different fields, from different institutions. So let's move into the brain anatomy 101. So for those of you that are not in the neuro field or haven't had a neurologist sitting down with you, or you don't have a neuroscience background, we talked about central nervous system, CNS, and when we say that, is the yellow thing. So it's basically the hemispheres of the brain, the cerebellum, the brainstem, all of that inside the skull, and the spinal cord. That's what we call the central nervous system. What do we call peripheral nervous system? The nerves. So all the nerve roots that come out of the spinal cord or the brainstem, those are the cranial nerves that go to the face, mouth, and eyes, are part of the peripheral nervous system. And it's way more than just the nerves. There's a bunch of little receptors and a lot of specialized stations in the body that are part of that peripheral nervous system. So when we think about the central nervous system, and this is going to be very relevant for everything we're going to be talking about and the results of the study, we know that if you look at the brain from the side, you have vessels coming in from the neck. And this thing that you see here is the aortic arch. So right below is the heart. And it comes with a common carotid, and it branches in two. One, the external, is going to go and feed everything outside the skull. The internal carotid, very important one, we're going to talk specifically what we learned about this vessel, is coming into the skull, and it feeds pretty much 2/3 of the entire brain. And then in the back of the brain, there is another vessel coming inside the little canals that are in the vertebral lateral processes, which is the vertebral artery here, coming from the subclavian artery. And this is forming a vessel called the basilar, and that feeds the back of the brain. And this is going to be important. We're going to review what parts of the brain are affected here, because when you hear my kid is having a TIA or had a stroke or has narrowing in one of these vessels, it's important to map it what it is, so you can be vigilant of what the challenges will be or could be, and what kind of resources can be applied or brought into the light by testing and also by doing rehabilitation. If we look at the brain from the bottom, this is a nice view to see that this thing that is what holds the brain, it's called brainstem, has different parts, and this is where all the vital functions happen: blood pressure control, respiration control, temperature control, how much water do I need to take or not take. All of that is happening here in the brainstem, and it's kind of an automatic part of the brain. And on top of that, everything that connects the brain with the spinal cord and the nerve roots and vice versa is going to have to go through the brainstem. That thing that was in the back, the cerebellum, the small brain, this area over here, we're going to see has a lot of functions, not only in motor coordination, but also in cognitive and in mood coordination and behavior. So I use a broccoli to replace my brain, and I'll show you, they call it the broccoli brain. When we think about circulation, I want to put a little note to the baby circulation, because it's relevant, super relevant for ACTA2 disease. And as you know, when we are in utero, the blood that comes with oxygen comes from mom, from the placenta, and it has to go through the right side of the heart. But the lungs are not breathing, they're full of water, amniotic fluid. So the blood that is not, that's super oxygenated, you see that is red here, directly goes to the left side of the brain, the heart, and then it jumps again through this PDA, patent ductus arteriosus, which is this thing here. When it's patent, it's called ductus arteriosus in the fetus, and it will shoot straight to the head. So the first best oxygenated and with all the nutrients blood in the fetus is going to have a predominance to go towards the head that is developing, and that has a lot of reasons: metabolic demand, but also the fact that the brain is much larger in proportion to the body of a fetus as it develops. And this thing, the ductus arteriosus, as the baby is born, will have to close. And guess who does the closure of that? Smooth muscle cells that have to kind of shrink and move and migrate and squeeze it. And that may not be happening, but not only that, when these two arteries, the pulmonary and the aortic artery, are separating, the smooth muscle cells are making the septum, the thing in between. So defects in that septation is what gives you the aortopulmonary windows, which are bigger, larger PDAs. Some people just call them large PDA. Most cardiac surgeons call them aortopulmonary windows. So the brain does not only have arteries, like any organ, has to get the blood out of the head, and it has a very specific venous system. Uh, we're going to talk that ACTA2 Arg179 does not affect the veins that much, so we're not going to be talking about the veins in the brain much. Very importantly, if you are a neuron, a nerve cell, and you want to be getting blood flow and nutrients, you're sitting here in the cerebral microvasculature. So the teeny tiny vessels all over the head. And to have effective blood flow, you need to have a good pressure coming from the arterial side, but not too much pressure in the venous side. And the brain is complex enough that it has this system inside, which is the cerebrospinal fluid system, where the ventricles and all the arachnoid sinuses will make the volume of fluid that you need. So when the heart pumps and sends the blood into the head, this ventricular kind of system allows like kind of a water buffer to allow the pressure to never meet resistance and not have effective flow. So when the heart is pumping and there is an oscillation, the ventricle accompanies that oscillation, and that allows you to have effective perfusion. And this is unique, doesn't happen anywhere else in the body. So the brain has a couple of things that are not the same as talking about the lungs or the liver or the kidney. So this is an MRI, and the study that we're going to be presenting, it has a lot of, all the data came from the MRIs. We also review CTAs and angiograms, and I'll talk a little bit about it, but it's not what we included in this publication in neurology. And it just came out in the last week of January in printout. So when you see this picture here, you're cutting the brain in this direction, and it's like someone is in a like stretcher here and is looking up. This is the back of the head, and their feet are towards you. So you can see that there is this changing in grays. This is blood flow. So this is how the blood comes into the brain, and then it gets darker and darker as it goes outside the brain. That's gadolinium contrast, and we call it cerebral blood flow. Important, you have to have enough blood. So if you have bleeding somewhere, you would not have enough volume to get into the head. And the other thing is that there is a specific timing, which I was talking about in these small vessels, that the flow has to be there. So how does the brain increase the blood flow? For example, I'm now talking in my left speech area. There's going to be more flow than in my, for example, muscles that control my foot, because I'm not moving my foot. So there's going to be flow redistribution. That thing is called neurovascular coupling, meaning nerve cell activity, electrical activity will call the vessels to dilate and send more blood flow towards that area. And when you hear dilate, always think of what these smooth muscle cells are able to do in the vasculature. So when the brain wants more flow, because it's feeling that it doesn't have enough, you're about to pass out, for example, what can it do? Can increase the flow itself from the heart, like opening a faucet. So I use the waterfall analogy. And this cerebral flow can be increased by getting the heart to pump faster. Very important, because we're going to talk about how this could be impacted by medications. And you need enough volume of blood inside the ventricle of the heart to be squeezed out, okay? And the other thing that we were talking about, the brain uses this vasodilation, no? So it squeezes here and dilates there, and it redistributes the flow. The other way to do it is with these teeny tiny capillaries and the smooth muscle cells that are over there at the beginning of the capillaries to redistribute the flow in a way that it makes it more homogeneous and efficient. And all of this is to really get the oxygen extraction to the maximum capacity that the brain needs. And it's constantly happening, constantly happening. This will be relevant for when we talk about cognitive and behavioral issues. Sometimes they're not related to injury to the brain itself, but to this mechanism not working, because it's very dynamic. So there are different types of strokes, and I'm going to say it up front. The first two in green are the ones that we've seen in ACTA2, venous thrombosis and hemorrhagic stroke. So a stroke is the sudden onset of loss of neurological function. So you stop talking, you stop feeling, you stop moving. That's a stroke, just the symptoms. Underlying the cause of those symptoms, there may be different mechanisms. So it might be an artery that got stuck with something or narrowed enough that doesn't flow any longer. That's arterial ischemic. There may be a total low blood volume or not enough blood pressure. So hypotension can give you hypoperfusion. Blood flow to the brain is called perfusion. Perfusion to any organ is called, blood flow to any organ is called perfusion. And venous thrombosis and hemorrhagic stroke, there's only 2 cases we found a teeny tiny dot of hemorrhage. So we don't believe that this is really relevant or happening in the disease. But remember that everything we say can change over time as we learn more about the disease. So if you never had to experience this, and that will be awesome, what is an arterial ischemic stroke? So I use this schematic. So you can see the brain, the arteries coming into the head, and basically it can happen when a clot travels and sits in the vessel and occludes the vessel, but it can also happen when the vessel narrows over time to a critical point that it cannot flow any longer. Whenever there is a sudden blockage, there's going to be an area of the brain that we call the core of the lesion, which is the brain that is going to suffer injury. And most of those areas are irreversibly injured, and you get a scar from that. But in reality, the symptoms that you're seeing have a ton more coming from this area of the brain that was fed by that vessel, but is still getting some flow from the other vessels coming from the other territories that are not stuck with a clot or stenosis or narrowing. And that is what we call the tissue at risk. This is important also. In the study, we found that this mechanism of kind of protection for brain tissue is not working really well in some of the patients with the ACTA2 mutations. And just to put a note on why do we use blood thinners, and blood thinners is a very big word, anticoagulants that affect thrombin, like heparin or oral anticoagulants, are the strongest ones. The milder ones are the antiplatelet ones. And I here have a vessel with platelets and a little clot being formed. The platelets are aspirin, Plavix, those medications that you may be familiar with. So we'll talk about what do we learn about those medications and the stroke and the history of the disease in these patients. The next injury is this one that I was talking about that does happen in ACTA2, which is the watershed or border zone. Border zone because it's the area between this vessel and the other vessel coming to feed that area of the brain. And the most impaired one in getting blood flow is this thing in the middle, which is called the white matter. So the brain has the nerve cells sitting in the gray matter, which is the cortex, this thing that does all these turns. And then the connections, the highways, the small roads are the white matter. And that's how the connections from here will get through all the way down the brainstem, the spinal cord, nerve roots to the muscles, and the sensory will do the opposite. So the white matter is one of the least perfused, the least capacity to adequate blood flow because it's so deep inside and there is less redundancy of vessels. And this is what we call a border zone injury. This can happen when there is severe hypotension. This can happen when there is sedation. This can happen for many reasons that affect that oxygenation in the blood, like for example, when you're sick from the lungs. I just want to show you that venous thrombosis, remember the venous system is very different in the brain, is not seen, have not been seen or reported yet in ACTA2 Arg179. And that happens when a clot sits in the veins and there is a sluggish flow to the areas that that vein is supposed to drain. And that can cause ischemia and damage to the brain. We haven't seen this happening. And the other one we haven't seen happening is the rupture of the vessel wall, the hemorrhagic stroke, and that causes the injury by directly bleeding into the brain. And it's a good thing because we are using a lot of blood thinners in these patients and we haven't yet seen that much. So this is my broccoli brain. As you can see, this is the front of the brain, this is the back of the brain. We call this the frontal lobe, occipital lobe. What is below this little fold here is the temporal lobe, and up here, the parietal lobe. The backpack, as I call it, the cerebellum, and a very important concept is gonna be this one. The whole brain doesn't work, even though I'm gonna show you where things map. It's not so straightforward, at least in young children. Why? Because this is developing. And what I'm trying to represent here is that this is a network. So a notch here with another notch here with another notch here would allow you to say that's a pencil. But it's not happening because you're seeing only, or you're speaking only, or you're moving your tongue only. You have to have the network combined working. And network means you have to go through the white matter, no? Through the highway, through the small roads. So connect the dots of the network. So if you zoom into the brain, for example, in an area where you have nerve cells, these are the nerve cells, and this is what forms the white matter, the myelin. So when you hear myelin injury or myelin disorder or hyperintensity, we're going to be talking about the area where these guys are. And this is insulation. So nerve cells connect through chemicals and electricity. And the way to insulate and make it more efficient and faster is to really put like a wire that you put the rubber around. That's going to be the myelin. So these cells over here called oligodendrocytes are making the myelin. This is if I isolate only one of those. These are nerve cells. This is where all the integration is happening. This guy is getting connections from many other nerve cells, and he wants to connect, let's say, with the spinal cord and say, move your thumb. And this is going to need over time that this myelin develops. And it's very important because it's not all at once done. And this is why when we show you the data of the study, we're going to have to take it with the limitations that we have on the imaging that we have. So white matter you see here in white is mature white matter, is what is represented in white. And you can see in 1 month, 2 months after being born, how little of your whole brain, look at the stage 5, more than 9 months of age in a normal brain, how little white matter we really have when we are born. And that's why the baby doesn't, like a giraffe, is born and walks and feeds by itself. It's feeds by itself in a way, but it needs a lot of help. And this is because there is a lot of maturation that is happening outside the belly. And it's important because when we talk about white matter injury in the infants in the study, we're going to see that there's some limitations in how we can label them. But we were lucky to have enough MRIs to suggest that there might be something happening over there. And if you get diagnosed very early on, you may be able to take some considerations to prevent that. So I want to show you this in the middle, and this is just another picture, 5 weeks, 8 months, and 3 years. You see how much black you have here? Now you see the cortex, and so nice, all the white matter. The white matter in this case is black because of the sequence. And here in the 5 weeks, you see there's a lot of white. If you see white on a 3-year-old, that will be injury to the white matter. So it cannot develop, or it has been developed, but it got damaged, and it will be replaced by that white patch. Okay, we call that hyperintensity, in case you're in front of your MRI reports. White matter hyperintensities usually represent injury, but there's very little we can say on these very early stages of development, because this does not let me see if there is injury or not. And we tried with the best sequences that we have, which is the next one next to it, to see if there is any subtle things that we could find. So the brain, as I told you, has a place for everything. So there's a place for sensory, so touch, temperature. There's a place to motor, so where you send the information, the plan of how a movement has to occur. And those primary areas, kind of the executive guys that execute, are in red. You can see the speech, and you can see the visual area, auditory, and then if you really want to make something complex and plan how to go up and down the stairs or play piano, you will need a lot of multimodal information, meaning sensory input from the hand, visual input from the eyes, a lot of motor feedback to see, did I do it right? Did you put the finger where it needed to be with that amount of strength and force? So all of that is in more and more complex network buildup, and we call associated cortices in the case. This is another view of the brain, just showing that all the other areas. And it's so much the map in the brain that the map really corresponds to very specific areas. And that's why when there is a stroke, we can correlate where the stroke is happening with the symptoms, even without looking at the MRI. Because we know that if the hand is not moving, we know where the hand maps. And you can see here the motor area on the brain. And this is, for example, the hand, and this is sensory over here. And if you made it a 3D picture, this is what sensory information would look like for the brain. So you see the hand has a lot bigger hands and tongue and lips, is because we have a lot of sensory input coming into the brain from those areas. So there is a lot more neurons dedicated to that area. Important in rehab and in development for the kid. We do not learn to speak without taking our hands and things to the mouth all the time, because these things are mapped together. And there is a way of reinforcing information and networks and feedback to make learning happen in a more efficient way. And you can see that motor, how little we have for our glutes. They're massive muscles, but we don't need so many neurons to tell the glute what to do. We need a ton of neurons if we want to really use fine motor skills, or our eye muscles. So this mapping goes on in the spinal cord. So the spinal cord maps each part of the skin to a particular level. So if the information is coming from T4, it will be coming from the nipples, and it will go to the thoracic 4 section of the spinal cord, and from there to the brain. And when we do MRIs, usually you're going to be seeing these pictures from now on. I take the broccoli brain, tilt it over, put it in the back, and then start slicing it this way. And now I'm looking, you see the eyes are up, the back of the brain is in the bottom, and the feet of this person are towards you. So this is going to be the left side, and this is going to be the right side. And what we see when we do MRIs is sections at different levels of the brain. So I use this analogy because when you think about a tree or a broccoli, you have a stem, and this is the brain stem. And it's like the canopy is kind of overflowing around the brainstem. And that's the cerebral hemispheres. And you can see that there is a black thing in the middle. Those are the ventricles. Remember, I told you there's a fluid system that is there to buffer that pulsatility of the heart, among other things. That's the ventricular system over here. And why am I showing you this? Because it's going to be important to kind of look at the pictures that we're going to be showing. I'm going to try to walk you through what the findings are without having to rely on the pictures. But I want you to have as much understanding as you can and you want to have. So this is one section of the brain, and this is a normal unaffected brain. And this is a specific sequence. You see how foggy this one is? But this is a sequence that's super sensitive to ischemia, to the acute injury to the brain. So in minutes, this turns on light in white when there is lack of blood flow or oxygen to a part of the brain. So this is an acute stroke. And what I want to emphasize is that the acute stroke that is happening does not necessarily match with what is going to happen to the brain, at least in ACTA2. We've seen all kinds of things. So acute injuries that are large and scars that are very small, or acute injuries that are large and scars that are bigger than this little one, for example. We do not understand what makes the difference. And there might be a lot of personal factors, other genetic factors, other predispositions, and what exactly is happening in the acute care. So when you want to speak, you need a lot of coordination between the auditory and language processing to the motor area that is going to allow you to phonate. And this has to be relearned if it was damaged, for example, early in life. In the vision, the one thing I wanted to say is remember that anything that comes from one side of the universe, this is for the whole brain, sensory and auditory and visual, will go cross and represent itself in the other side of the brain. So when we have an injury to this particular pathway, you may lose sight to the external aspects of one visual field, for example, or you may lose sight on the middle of the visual field. Why am I showing and going over this? Because you have to ask your neurologist if there is injury to the visual pathways. Why? Because this will change the monitoring and the treatments that you need to be doing for the kid or for yourself. So I told you these things get really complicated. So there is a where pathway. So where is that? So when we think about something, you always make a map inside your head. And that where pathway requires a lot of visual information, but many other areas. And the what, which is I put a pencil in front of me and I look at it, I'm processing visual information, but I'm gonna name it, is a pathway that goes to the temporal lobe. Sensory comes in very different flavors. So you have temperature and touch and injury, so pain. And these guys will travel up in the spinal cord, which is depicted here, to the brain. And in the motor system, it's going to be exactly the opposite. It's coming from the brain, going down through the brainstem. These are sections of the brainstem into the spinal cord to get to the muscle. And from the spinal cord, that neuron is going to tell the muscle contract. And that's constantly being sensed by a reflex that is very important. It's the one that we test with the hammer, that when it's altered, it will cause spasticity. Because every time you want to move a muscle, you need to coordinate the other muscle to relax. And when there's no boss and there was injury by a stroke, you may lose the ability to control that reflex. And then it's too much contraction of those muscles that fight gravity. And that's called spasticity. And this happens and gets exacerbated whenever you're tired, sleep deprived, not eating, because kids that have had a stroke or people that have had a stroke will use compensatory mechanism, the reserve. And if you take my reserve, then you're gonna see things that you usually don't see. In ACTA2, you gotta still talk to your doctor because that could be a TIA, and you have to learn to distinguish what is what and what to do in those cases. So this is a reflex that I was telling you. Just to say that backpack, remember the little cerebrum in the back of the brain, coordinates a lot of things. It's not just movement, but one of the tests that we do all the time is finger to nose, or we ask you to go specifically at the target or do this with your hands or tap on a finger. These are the functions that we're testing to see if there is any disarrangement in this coordination. We have seen very little injury to the cerebellum in ACTA2, but it's the first time that it's being reported officially that there could be involvement by the vascular disease on the cerebellum in these patients. So to keep in mind that this is being evaluated. And the cerebellum is critical for your balance. So sometimes if a kid is clumsy, or someone is clumsy, you have to think about what it takes to be balanced. It takes a good visual system, could be affected by the white matter disease. It takes a good vestibular system where your head is, and then a good proprioception. This is the information that comes from the muscles and the joints to tell the cerebellum that where are things when the body is moving. There's even more complexity to this motor system, which is also cognitive and mood and spatial ganglia. So in some of the strokes, damage to basal ganglia can occur. And you can start seeing other things that are a little bit more difficult to diagnose. But again, what I'm trying to emphasize is look and ask, where is the stroke? What areas are being affected? How does that shows as the kid develops? Not now, but in the future too. So why do we do research? And the idea is that we want to get to treatment. And we want to be targeted. We want to be as specific as we can to avoid the side effects. To do that, we start with the patients. And then you build expertise and you bring a multidisciplinary team. And I'm quoting here what you probably may or may not need, depends on the disease symptoms that you have. And we then work on describing what the disease does. That's called the natural history of these biomarkers, as we are doing now, the progression in MRI. You, of course, have to go molecular and what exactly the gene is doing to the cells, and we'll talk a teeny bit about that. But very important, if you're ever going to treat, you need to learn when and what is going to change. And that's why we need, in a rare disease, everybody to participate in research all across the world. And both Dr. Milowitz, which has been doing this for more than 3 decades and has the largest database, and us are trying to put our heads together and trying to understand the different aspects of the disease in order to be able to one day bring therapies to the patients. So we're going to switch now to ACTA2 specific. And you know, and you have heard that it's a smooth muscle disorder. And just to put it very clear, it's not this muscle. It's not the striatal muscle, the muscle that moves the body. Smooth muscle is in all the organs and the vessels, okay? That's where the smooth muscle is. Also in the skin. And that's why most of these people do not get goosebumps. And they're very difficult, have difficulties with sweating as well. So smooth muscle is what is in red here, and you can see a large artery and a smaller muscular artery. When I told you the vessels constrict and dilate, are these guys over here, and these arterioles are the ones controlling the blood pressure. These guys are the aorta. They are just conducting the blood, and they also need to recoil. So the blood pressure between the high and the low, the systolic and the diastolic, is not so wide. And that also prevents a lot of stress to be seen by these vessels over here. If these vessels get stressed, they're gonna try to narrow to prevent damage to the little guys, which are the capillaries, which is where all the tissue and the exchange of oxygen is happening. In the veins, we don't see so much affection, and we're trying to understand this. There's some things that we are seeing in lymphatic system, venous system, but we're not clear about how it's happening. One possibility is that the veins also express a different type of smooth muscle actin. This is SMA, smooth muscle actin is the alpha one, is the ACTA, and the gamma is what veins have. But if you look at arteries, they have teeny tiny amount of gamma actin. So arteries really rely on this particular isotype, which is abnormal. So if you shoot an angiogram and you have here the iliac, femoral, and going into the aorta, arch, and going back into the heart, you can see the vessels going into the neck. This is what the vessels look like, very smooth and a particular size. And this is what we see on, for example, an MRA of an ACTA2 patient, which has dilatation, fusiform, aneurysms of different portions of the aorta, and not only the aorta, but also the vessels that go into the neck, like carotids that I was talking about. And that's going to be very critical. We're going to zoom into the brain. I'm not asking you to look into the teeny tiny picture to see how these vessels will change over time. So this is a new disease. Diana put this in the map in 2010 when she described 5 patients that had this multisystemic disorder. There were more than just the heart, the vessel, and the aorta. There were also the bladder, the gut, prune belly. And since then, she's been putting a lot of effort in understanding the genetics and the molecular mechanisms of the disease. And now we're trying to go into how is this altering cerebrovascular function, brain function, and causing stroke and white matter injury. So for those of you that never heard about it, this gene codes for a protein that is supposed to make these beautiful chains of protein. Each protein is one of the blue dots. and they have to kind of couple one to the other. When you change the arginine 179 to this, for example, histidine, which is one of the most common mutations, you kind of lose your keyhole for this interaction that has to happen between yellow and green, between each of these little blue dots. And what you end up having is abnormal polymerization of fibrillary actin, and that will give you abnormal cytoskeletal function. So this is a smooth muscle cell here. And the fibrillary, the actin fibers are these ones over there. When you want to constrict, when you want to make the cell smaller, those things roll one over the other as rails, and that produces the contraction of the cell. And this is a nice representation of when you have a normal arginine in your protein. This is how the two proteins interact with each other, very tight. And this is what happens when your arginine is mutant to a histidine instead of that amino acid. And that is too much of a space, and we think is unstable for the protein to really work and do the function of cytoskeletal that it needs. And that has a ton of consequences that are very complex, but very schematically, when a cell cannot sense the extracellular matrix, what's happening around them by doing these movements, when it cannot move to make new vessels, or when it cannot really constrict to make the blood pressure go higher, it will start proliferating. Proliferating means making more of itself. And that making more of itself, we take a toll on the vessel lumen, the area where the blood flow happens, by proliferating, by having many, many cells go over into that area. So that is what we've seen. This is an ACTA2 vessel in the Munot paper that you guys probably know as well. That shows that this is happening in the dural arteries, and we've seen it from a postmortem study that it's also happening in small vessels and arterioles in the brain. So in 2018, we collaborated with Diana, and just to contribute on neurovascular and what we could do up to that moment, we published the first 33 patient cohort and the history of what happened in this disease. But just to summarize it, all patients have these eyes dilated. All patients had the PDA or the aortopulmonary window. All patients at some point will develop aortic disease. And the low blood pressure and the dysautonomia, and I will go over that in a little bit more, happens in most patients. Lung disease is under study, but is very critical, and it can cause a lot of problems, including stroke. And then the gut dysmotility, malrotation, and a prune belly if it happens early in development, as well as the atonic bladder. And I scratch asthma and aniridia because I still leave them there because people are gonna get to Google by what their physicians are telling them. And sometimes these things are misdiagnosed. The kids with ACTA2 do not have asthma. To have asthma, you have to be overreactive smooth muscle cells. These smooth muscle cells are not overreactive. They have more a fixation of those airways that are narrow, maybe, but more important, they don't distribute flow. When the lungs are aerating here, they cannot send the blood flow to that area. The same way that in the brain, they cannot redistribute flow to the areas that are more active. This is super important because if you guys can advocate for something, is to teach every pediatrician and every neonatal intensivist that if you see a kid with dilated fixed pupils and a PDA or aortopulmonary window, this is ACTA2. There is almost no differential diagnosis. And in the call, I know of some of you guys that have come to diagnosis because of this combination of things. And many of them by the parents doing the Googling. We learned from that first natural history that the aortic events, the replacements, the dissections tend to happen later in childhood for most patients, so after 10 years of age. But in the cerebrovascular disease, and we're going to put a lot of emphasis now on this, we are seeing that happening much earlier in development. So before 6, 7 years of age, a lot of these kids have encountered white matter injury, a TIA, or a stroke, unfortunately. So here I'm showing an angiogram, and you can see that this is a normal angiogram and how nice tortuous the vessels are. This curvature here, this is the carotid coming into the head. And that's the end of the carotid, the internal carotid, and where the branching happens. And this is the end of the internal carotid in a 5-year-old with ACTA2 and how their vessels look like. And you can see for yourself that they're straightened out, they're very narrow, and they are also having what we don't see here, even though they are narrow, is extra vessels that the brain tries to do when it doesn't feel that it has enough blood flow. So This narrowing, we know from the little studies that we have in humans that is probably at expense of this proliferation of smooth muscle cells that is a compensatory mechanism most likely. So the patients that we studied, who were they? What were they like? So we studied 27 patients that we had available MRI. So remember, there were 33 in the first natural history. Of those, only 19 had MRIs in that. And then many more patients were added through our database to make these 27 patients with not only one MRI, but many MRIs. And you can see the age at the first scan, but the variation is very wide. And I want to mention this because it's important to take the results into context. This is going to sound all like the truth. It's not the truth. It's what we saw in these patients up to now. And I just want to show you that there is a wide variation of what we are able to analyze. The things that become statistically significant, we do believe are telling us a story. And that's why we do this work, is to find the story to see how we can intervene on that. And you can see that only of those 27, only 4 patients die in this cohort. And of those 4 patients that we put here, what were the causes of those, the death of those patients? And pulmonary complications, the aortic rupture and the stroke, and one of them undetermined by the medical records that we got access to, were the causes of death. So the other thing that we saw is that the seizure frequency is slightly higher than what we knew. Clinical symptoms of a stroke, meaning reporting stroke symptoms, was more or less what we saw in the first study. The headache component has been dramatic. There is a lot of patients suffering from headaches of different kinds and migraines that can be even disabling. And then the eyes being dilated, the reports that we had said that 70% of these patients had it. And then you can see the bladder. And then here is the diagnosis of a stroke in imaging. So you can see that the MRI shows more strokes than what the patients are being reported with. And that can happen. The stroke can be silent and cause injury to the brain without really causing symptoms. So a lot of these patients, as you can see, had PDAs, 92%, or aortopulmonary windows, and other aortic classic findings of ACTA2. And this is important. What were these patients treated with? And they were treated with the intracranial, intracranial bypass, EDAS, revascularization surgery is also used. And that was only available in this cohort in 5 patients. And how many patients were in blood thinners of the strong kind, the anticoagulants that we have? 5 patients. And then what are they? Antiplatelets, and 70% of those patients that had blood thinners were just taking antiplatelets. I don't say just because it's bad. I'm saying that they were not on heparin or Lovenox. That's what we're trying to say here. And then we were asked by the reviewers, did the strokes happen when they were on antiplatelets? The truth is, most of these patients were already on something, so we couldn't say if they are preventing strokes or not. But having a new stroke while on antiplatelet happened in 3 patients, so 15% of them still had strokes even when they were on a blood thinner. I want to make the distinction that this is moya-moya disease, and you can see a lot of smoky stuff. Those are teeny tiny vessels, and we don't see so much smokiness in ACTA2. Most patients don't have these collaterals. It's relevant for the hemorrhage risk. When there is a ton of these tiny little vessels, as adults, patients with moya-moya disease tend to have bleeding. We're not seeing that happening in ACTA2. In terms of the other injury to the brain, I told you about arterioischemic strokes, and we go a little bit more in detail, but white matter injury is pretty prevalent. Like most patients, 92% of our patients had white matter injury of some sort. And in the white matter, I told you, we have the smallest vessels in the brain. And this was one of the findings that was never shown, that is injury to the white matter in the center of the brain can happen as early as 7 days of life. In fact, we have an MRI on a 2-day life, so right after birth, and a kid that was having hypoxia, and that person had white matter injury at that point. And remember what I told you about this kind of white matter injury in these particular aspects and features, that they're usually the result of hypoperfusion, so low blood flow to the head, either by hypoxic events that can happen because they have a PDA or an aortopulmonary window, and you might remember the saturations were low, or it can happen during the delivery. The delivery is a pretty stressful time. Or it can happen during the surgery for the PDA. A lot of these kids were never known to have the disease before they got repair their PDA or aortopulmonary window. So they were using the same procedures that they would use for other children that don't have so much impaired neurovascular coupling. And you can see one thing that was important to us to say, because I've been asked millions of times, the white matter disease, is it going to progress? Is it going to get worse and worse and worse every year? And the answer in short is no. What we've seen is more like an event. If an event happens, you may get a hit to the white matter, but it tends to match 7 years, 10 years down the line, pretty much to what you got when you were a baby, an infant, less than 2 weeks old. In the patients that we had MRIs when they were infants, of the 27, we only had 11 patients MRIs when they were kids. So to that question, is the volume, the amount of white matter, patchiness, and injury increasing? The answer was no. We did see these little cyst-like lesions. We think they're perivascular spaces because of their characteristics, but we can't be 100% sure. And we did see some patients have increased numbers of those as they get older. And here you have the age, and here's the volumes, and here's the number of those cystic-like lesions, as we call them. So in the white matter, basically, we see it happening very prevalently in everybody. We see that it's pretty much stable in terms of volume, that the cystic component may change in it. But we did wanted to point that when this injury was happening, this vessel, the internal carotid and the cerebral arteries are still not that narrow as they will potentially become as the kid gets older. So this is not caused by narrowing of those vessels, of the large vessels at the base of the skull. And this is what we think is what we call watershed injury, as I was saying. So what do we do if we have white matter injury? This is where we're going to go from the study to some sort of like approach, and kind of a recommendation of how to think about it and what could I be doing for myself or for my child. If you have a network problem, because the white matter is the highways and you can't use the highways and you have to use the small roads, you may have a slowing of processing, and that could give you cognitive problems, impulsivity, attention deficit, overreactivity, aggressiveness. A lot of these functions that I'm talking about are here in the frontal lobe, which are a little bit long and far from the base where the arteries are wider. And that may be the redistribution of flow plus the stenosis contributing to that. And because we see this in every patient I've followed so far, we do recommend that these patients get neuropsychological testing. And I will start at 3 if you can find someone that can do it, but if not, at a school entrance and before first grade. Why do we do that? Even if the kid is talking, walking, looks normal, we are not benefiting them if they have a slowness of processing and they just need extra time for learning, for like assignments, or even for testing. And that's very important to have, to not destroy the self-esteem of the child as he goes into a school and develops a peer group. A lot of these patients will suffer depression, and in kids could be difficult to diagnose, but a lot of you are very familiar with what I'm talking about. And those can have symptomatic treatment. There are medications that are really good. You always will have to run any medications that are given for this or anything to your cardiologist and your neurologist. They both have to say, okay. So you're not at risk of getting low blood pressure or a stroke. Autonomic dysfunction is this what I'm talking about, that all these smooth muscles are innervated by these fibers that come from those centers in the brainstem that are automatic. Bladder and bowel control comes from that. And we know that it's both the smooth muscle in the gut, but also the connections with the brain that could be altered because of the white matter injury. POTS, I don't know if you heard, paroxysmal orthostatic tachycardia. So when someone goes from lying down to up, you start getting tachycardia. That's what the heart is trying to do, to pick up increasing blood flow to the head, because as gravity changed and blood was not so favorably going up to the head, in this case was horizontal, so now it's vertical, you have one very quick, rapid mechanism, which is increase your heart rate. We want every kid and every patient with ACTA2 to have the ability to increase their heart rate ad libitum, whatever they want to do. So do not use any drugs that control too much the heart rate. And this is something to discuss with the cardiologist. Why? Because this is a mechanism they have to prevent hypoperfusion, watershed injury, and TIAs and stroke. Erectile dysfunction is happening. And this is something that as patients get older or become teenagers, we have to be mindful to ask about these things, because there is also treatments for those. It might be tricky in ACTA2, but there's still a lot that can be done by even talking about it. Auditory and visual processing. I told you everything could be slow because of this white matter injury. So formal testing, what do I mean? Auditory central processing is not done in the neuropsych evaluation. It's a separate test, and it will come with recommendations as if there is any device that can be used to increase the frequencies that the brain has more trouble processing, to recognize voice primarily. And in this case, I have kids that in the classroom, the teacher has to use a microphone and speaker, and not only the kid benefits, the entire classroom benefits, because now you can hear and discriminate much better the voice of the teacher from the background noise. A kid that has white matter injury and auditory processing will be doing this when there is a lot of noise, will be refusing to go out to a shopping mall or noisy places, and it will look like ADHD because it can't pay attention to what is being said because it's overwhelmed trying to processing and decode language from background noise. These things can be done, take forever to get an appointment. But when you have it, and please make sure that you go to an audiologist in a children's hospital or in a large institution that has experience with kids that are not going to be able to do the testing so easily because of their attention deficit. Lacunar infarcts can be happening in the white matter, so small, teeny tiny strokes. We've seen very little of this. And we, for lacunar infarcts and for other kinds of strokes, are still using antiplatelets as a way to prevent. This comes from the adult and the pediatric literature on other types of stroke. And then commonly associated with ophthalmological abnormalities, meaning the accommodation, the pupils are dilated, you need sunglasses, and in neuro-ophthalmologists, we'll be able to tell if the visual processing is being affected by white matter injury or not. So not only an ophthalmology run like every year, but a neuro-ophthalmologist at least once to make sure that there is no cortical visual processing issues. So we talked about the stroke in acute. So what can we do for acute stroke? Remember that I told you there's a tissue at risk? Because the smooth muscle is not really accommodating flow the way it could, these patients can have during the acute stroke an expansion of that tissue at risk into further areas. And in fact, in this article that we just published, we've seen this happening at least in a couple of patients. And this is the one that best describes it. This is before a surgical procedure was being done. This was revascularization because she had teeny tiny vessels and was having already strokes. You can see stroke here, 2 months prior, and comes out of the surgery totally fine, surgery is successful, and 30 hours later starts suffering ischemia, and the strokes spread like a little bit like a wildfire. And that's the failure of these smooth muscle cells to redistribute and adapt to the changes that were happening. And I've seen this without any surgery, and most of the time triggered by either dehydration from diarrhea, a travel, or by anesthesia. So you have to be careful about these things. I'm gonna say it 20 times in the next 10 slides. And I have another 5 minutes, and then we'll open up for questions. So what do we see about the large vessels? So I told you that at the beginning, we see this carotid artery that is dilated, but then it narrows as it gets into the branching point, that terminal ICA, terminal internal carotid artery. And then we see a lot of critical stenosis happening, so a lot of narrowing in other vessels. And so what we did was we look at where the strokes were happening in the MRIs, and this is the percentage of the area. So you see most of the strokes happen in the carotid territory, not on the vertebrovascular territory. You see the little incidents in the back of the brain, the cerebellum and the brainstem. But when you look at the critical stenosis, they pretty much correlate with where the strokes are happening. And here we measure it for every single patient over time. And critical stenosis seem to be progressive in the sense that over time, more vessels can get narrower and narrower. Arterial ischemic stroke is not the same story for everybody. And this is where all the hope lies on. There seems to be an event-related trigger for the strokes. And it's not that we can prevent them all, but it might be a way to approach some of the care that we need to do for these patients to minimize that risk of stroke. And you can see how many patients have not had a stroke by the time that we study their MRIs in this study, again, with all the limitations that we have. Remember, here you have a head of a child, this is the eye, this is the nose, and this is the carotid. It's looking to the other side from all the pictures that I've been showing. And I'm showing this because this is the last part of the story of the large vessels. And is that we saw the carotids get larger. This is the elastic portion of the artery. And the carotid, normally you're born like this, okay? And then you develop this kind of S shape that it should happen here. This should not be just like a little slide, it should be like an S-shaped vessel. And that is on purpose to diminish the stress that blood coming from the heart will get to see the cerebral arteries. So the cerebral arteries are not so stressed out. This is the anatomical explanation of why we develop this S shape and we have these Cushings where there is kind of buffer of that shear stress. But when we look at ACTA2 patients, what we saw, and here you have at 10 days of life and at 7 years of age, we saw that that carotid, now I'm changing the way you're looking it from the front. In the green area has a size, on the red area, the terminal ICA has a different size. At 10 days, this is the ratio. So I'm showing it here in bars. And as you get older, this tends to get larger, so dilates, and this one tends to get smaller. And that ratio increases. And this is what happens in control. You can see the ratio doesn't change that much in between 60 days of life and 7 years of age. What we found is that the wider this ratio gets, okay, above 0.7, we will start seeing arterial ischemic strokes happening. And that's very important because it gives us a target to prevent the initiation of things when we don't think they are so high risk of having stroke, but it also gives us a target for treatment. Can we prevent this from happening when we get to a therapy? And it is important because if you look at here, all these blue guys are patients with a stroke, kids with a stroke that do not have ACTA2 or a vasculopathy. And you can see that that ratio that we're talking about is not really, is almost not at the same level that happens in the ACTA2 patients. So that's something that we know is very specific of the disease, and it has an implication on white matter injury and arterial ischemic stroke. So the two types of injury that we know are ischemic. Also very important is that you can check on this without doing an MRI with sedation and all the stuff. You can do it with transcranial Dopplers. So they had to look at the carotid in the neck, and they look at the carotid at the top of the carotid, and then the cerebral arteries. And over time, if you follow this every 6 months, for example, you will be able to tell if there is narrowing happening or not, without having to put the kid on an MRI or the adult in an MRI. It's difficult to find a technician that does it in young children, but that definitely it's been done because sickle cell disease has this as a standard of care for infants 6 months and older. So there are places where you can find transcranial Dopplers, or at least in most developed countries. Time is brain, we say, when you have an arterial ischemic stroke, an acute stroke. And all the care in adults, and what I do when I'm on call, is trying to get that vessel that got clotted or narrow or occluded to reopen. That cannot be done many occasions. Sometimes it's too late because there has been too much ischemia, and if we reopen the faucet, we will get hemorrhage instead of benefiting the brain. But there is a clot buster medication that you can give to patients that present with a stroke less than 4.5 hours. We have one patient that received TPA that we learned from, but we do not really have any information about TPA on ACTA2 Arg179 at the moment. What is very important that you do seek medical attention, because I'm going to talk about other interventions that can be done. And this is what TPA does. The clot is made of platelets and fibrin, and TPA gets rid of this mesh that traps the platelets in the clot. So it basically dissolves the clot by dissolving the mesh that keeps the platelets together. And the idea is that you perfuse that vessel, and that area at risk, remember, gets to see blood flow again, and it doesn't die. Can revascularization surgery, EDAS, this is the most common one, or direct anastomosis benefit these patients? What is published so far is 50-50. 50% of the cases that were published had events during surgery or strokes after, and 50% of them had not events after surgery. We are now collecting any person that has had this surgery, their MRIs and angiograms, to answer that question in a more informed way. Basically by having as many patients as possible to really know if that's the case. Should we be doing this, and when is it good to do this surgery? And can patients tolerate it? And how do we prepare them for surgery? So there is a case that is successful. What were they doing? And it will only be available for others, and as we really put together all the data and publish what is really happening. So we learn the best that we can. So in summary, we talked about that most of the events in the brain can happen early in life, but this is what matter is not the large strokes, that stays kind of steady, that then you can start having arterial ischemic strokes as your carotid terminal narrows, and that later on you will have to be followed very, very carefully from your aorta and may require surgery in different parts of the aorta to prevent dissections. I wanted to say something that Dr. Kinan, our pulmonologist, teaches us. The lungs are in play in all of this. I told you that the brain senses the oxygen, and when it doesn't have oxygen, it has to squeeze to redistribute the flow. The lungs in ACTA2 have the inability to septate the alveoli where the air exchange happens. So these guys get this septum as they develop by the smooth muscle cells, and these guys are not moving effectively from what we know. And not only that, the vessels that feed the lung, when they need to redistribute, if there is mucus here, for example, I have a pneumonia and this part of the lung is not being aerated, you need to redistribute the flow to the area that has air exchange, so I can oxygenate effectively. And that is something that kids with ACTA2, we've seen in critical care over and over and over, have difficulty with. In a lot of places, they are calling this pulmonary hypertension. And when you look at the echocardiogram, they do not have increased right ventricular pressures. That is a little bit of a hint that is narrowing of the vessels from this intima proliferation, from dysfunction of the smooth muscle, that is causing that difficulty with redistributing flow in the lungs. Important because there are medications that can improve this, and one of them is oxygen. And when you have to wean oxygen, be very, very gentle because they cannot redistribute the flow themselves. And this has made a big difference. So what do we do with all this, and how do we improve the care? These are the recommendations for monitoring. We published this in the 2018 paper. So we are recommending neurological and hematological. You want to know if you have a bleeding problem or a clotting problem in your blood on top of ACTA2. And we are studying the platelets of the patients with ACTA2 to understand if the disease, the mutation, causes any platelet dysfunction. And there will be more to that story with Dr. Grabowski. Rehabilitation specialist is super important. The physiatrist could help a lot to get the resources to thrive, even with having a disease that causes so many multisystemic problems. The neuropsych evaluation, the hearing evaluation, and the central auditory processing evaluation. I talked about the neuroophthalmologist. Contact a vascular neurosurgeon. You might need them. You want them to get to know your case. And make sure that they have a lot of experience in Moya, and if possible in ACTA2. EEG, electroencephalogram, only if there is concern for seizures. We do recommend a baseline MRI, but I do ask all parents to try to get the non-sedated MRIs. So a lot of children's hospitals are at the moment able to do non-sedated MRIs, basic ones, but they're good enough to get the data that you need. Is there a white matter injury? Is there a stroke? Are the vessels narrow? And that data can be acquired with a non-sedated MRI. What happens is a lot of times you had to bring the kid back many times, you had to have child life, and that's not available everywhere. If they're gonna go under sedation, you have to put the stop and ask them to talk to your neurologist and your cardiologist that knows about the disease. Because adjusting the anesthesia and how they get induced and intubated will diminish the risk of stroke. And that we know it not only from ACTA2, we know it from Moya disease. So you have a lot to do about the anesthesia that you can do, even for other procedures that are not invasive. Avoid CT scans just because we don't want them to have a lot of radiation going to the head. Transcranial Dopplers, remember I told you, can track this narrowing of the vessel that is critical. And a catheter angiogram only reserved for when you're gonna be doing procedures, either heart surgery, aortic surgery, brain surgery. We do not recommend going to put a catheter because healing of those vessels could be different, and dissections are much higher risk when you have a catheter going into these vessels that are already dilated and thin in the wall. And here I'm gonna stop and pause, and I'm gonna drink. And I'm gonna make it so graphical. I also needed to keep talking. But hydration is the most effective measure to diminish the chances of not having blood flow going into the head. And kids are kids, and adults, and I don't drink at all during the day. Most of you guys maybe not, but there are ways that we can teach and learn this behavior from very early on. And these are kind of smart bottles. They tell you how to drink. They glow when you haven't drinking for some time. And most of my patients are very fanatic of these things. because hydration can prevent, when there is low heart rate and low blood pressure from changes in position, from sedation, from whatever, the possibility of having not effective blood flow to the head. So please do not underestimate what hydration means. And for those of you that are on feeds, on pump, always make sure that the total amount of fluid in the day is very well thought and a little bit extra in free water, no? Not just food for food, but in free water. It's something to discuss with your care team. Antithrombotic therapy in childhood, if no previous bleed, we have to still say we know this cohort, but not all the cases in the world, and maybe not the whole story for the disease. And if there is no large amount of basal collaterals, this is because some of the kids we've seen that they have basal collaterals, but we don't know if they're gonna get more. In moya disease, not ACTA2, if you have a ton of these vessels, after 20 years of age, 30 usually, you can have an increased risk of bleeding from those teeny vessels. So we change the dose of the aspirin, or we stop it, or we change the Plavix. So something to ask, do we have a lot of collaterals? And that's very specific to the particular patient. Avoid iatrogenic hypotension. Iatrogenic means we do it, the doctors. And that's medications. So always run the medications by 2 people. Avoid sedation, prefer dissociative anesthesia. What is dissociative anesthesia? Ketamine increases the blood pressure instead of decreasing it. Every other anesthetic decreases the blood pressure. So that's one option, ketamine there. The other one is dissociative anesthesia with Haldol. There is a medication that we use to not be able to be there when you are doing a procedure. It's not for invasive procedures. If I'm cutting, I can use this, at least for a cardiac surgery. But if I'm doing an MRI or they're doing a urinary tract study, this is something that you could ask. It's like, could we have a different anesthesia? And then have them get in contact with your cardiologist or with the team. And we are trying to put this in a paper with Dr. Milowicz and a larger cohort of practitioners that have been encountering patients with ACTA2 to give some guidance to people that do not see more than one case of the disease, which is most of us. Avoid hypoxia, and I say treat early with low oxygen. Don't wait till saturations get really bad, and you have to know your cardiac history a lot, and the cardiologist will help you with that. But you will need a pulmonologist in your team, and it has to be someone that knows about smooth muscle issues. And there are many other diseases causing smooth muscle disease. So it's not that there is no ACTA2 and nobody knows how to do this. So if there is an expert in smooth muscle disease, could be very good to have in your team. I have this window here. Altitude. This is a totally made up recommendation, and I take it from the neurosurgeons. 6,000 feet and above, the oxygen tension will go down in the atmosphere. We know that when the oxygen goes down, you should be able to redistribute your flow in your lungs and compensate. But most of us will even get a headache if you're going too fast quickly up. And that is because the vessels are trying to constrict. There's a response to hypoxia. That is something that these kids cannot compensate very well. So be mindful if you're going up. I do have an ACTA2 patient that is a skier and it competes and it goes up, and she has to be ready in case the gondola doesn't work and they shuttle her to the 10,000 feet. So she carries a canister of oxygen with her in case that she gets up, and then she does a couple of puffs. She has horrendous migraines if she suffers hypoxia. So she knows her disease as well. So the last part, pregnancy and postpartum. Smooth muscle affects the uterus, and also people with a smooth muscle disease, with the aortic disease that we see in these patients and other vessels, may be at higher risk of dissections during the pressure that you have to do in a vaginal delivery. So this has all to be considered and discussed. There is headache management that I was talking about. Importantly, run the medications by the neurologist that knows ACTA2 and by the cardiologist. And hydration is one of the best things to prevent all kinds of migraines in moya disease. And then this is the management of acute stroke, is primarily flooding them with fluids until we see what's happening in the MRI. We try to keep the hydration at 1.5 times the normal rate that you will hydrate through the vein. And you can do that even before the MRI happens or the CT happens. And then we let the blood pressure do whatever it can do, because it's trying to provide blood flow to the brain. We don't lower blood pressure if it's high when you're having an acute stroke. And administer supplemental oxygen may be helpful for moya disease. I'm taking the recommendations from moya that we have best data for. Minimize crying and hyperventilation. When you hyperventilate, you can pass out. Guess why? You get squeezing of the vessels and low blood flow to the head. So you try to do this, which means sometimes you have to put EMLA if you're going to do a procedure. You may have to do child life or cognitive behavioral therapy to be able to cope with the interventions. And if you are in the critical care unit, we use morphine and dilaudid before we suction the tube, before we change the catheter, to diminish the possibility of that stressor. And in the absence of clinical seizures, we do not recommend being on an anti-epileptic drug. And the reason is we don't want them to be sedated. We do use anti-epileptic drugs that don't have vasoreactive activity and don't cause too much sedation at lower doses to prevent migraines, to the headaches, for the headaches. So you see how complicated this gets? You do need to have the conversation. But what we are aiming to do is to equip you with the questions, at least, to be asked to the providers. And then the recommendation for moya-moya disease, for those that have a lot of collaterals, and that's what I was talking about, the teeny tiny vessels, is that avoid TPA because they can bleed. But a lot of physicians say go case by case, and that's what we recommend. If there is a large vessel and you think there is not too much stenosis already because it's fixed and that will not work with the TPA, you could potentially offer TPA. And then if there is a large stroke, the conversation of opening the skull in case there is swelling will have to happen early on in the first 2 days after the stroke. That's called decompressive hemicraniectomy. And then we try not to constrain the jugular veins for constraining the venous return, as we were talking, that can decrease the capillary flow. I told you about revascularization surgery, and we don't see a lot of angiogenesis happening with this disease, and that may be one of the reasons why they're not doing so well, and they're not doing as well as other moya-moya patients, at least from what is published. But we do not yet know, and we are asking everybody you know that has a surgery to get in contact with us so we can do the study and try to bring an answer to that questions. And this is the last thing I'm gonna say. Every child and every adult have their own developmental curve. So the way to look when you have a disease that affects so many different systems and affects the brain is what is your child or yourself working on? And what is the support that you need to learn the skill that will bring you to the next milestone? It's not about, am I sitting at 6 months? Am I walking at 1.5 years? It's about, what am I doing right now? Oh, I'm controlling my head? Okay, I'm gonna go work on my belly. So now I can start getting my chest up. Oh, I'm controlling my trunk, and then I can work with my hands. But we don't try to sit them up and put them to do things with their hands when they cannot control their head. Because what you're doing is hampering that learning capacity. So always develop with them all the strategies that can help their developmental stage. And we believe that educating parents is the best way to get advocacy for them. And we talk about how many things we don't know, but the ones that are living with this disease is you guys. And even the clinicians, it's very difficult to be in front of patients that we don't know how to treat, or we don't have a perfect answer for their most critical events. And it's important that we recognize that and what matters the most, because that's what we need to try to treat first. So help us understand, and thank you for letting us be part of this journey by participating in the studies, by coming to these different centers that are trying to learn about ACTA2 so we can build the knowledge to help you guys. And with that, we will open to questions.
Thank you so much. So if you have a question, just put it in the chat, and then I'll call on you, and then you can either say your question out loud, or I can read it if you prefer it that way. So the first question that we had in the chat was from Jay Biblau, and they ask, I've heard that the older the kids get, the stroke risk decreases. Is this true? And if so, why?
So remember that I show you what the patients we have look like. We don't have many adults. And adults, I'm referring people above 21 years of age. So to say that the strokes don't happen later on in life is a reduction. I don't think we know that part. And remember that many of them will have had aortic replacements, and some of them including the valve. And if you have a valve, there is a higher risk of a different kind of stroke, which is a clot forms in the valve and travels to the head. And in fact, the strokes that we saw happening in adults above 27 years of age were this kind of strokes, were embolic strokes from having to stop the anticoagulation for a procedure, for something, and a clot being formed that travels into the brain. What we do believe it may be happening is that because it's a progressive narrowing of the vessels, the brain is trying to figure out mechanisms, and one of them is controlling the fatigue. And I don't know if you guys have experienced this, but most of the kids and the teenagers and adults that I follow have a very low tolerance to exercise. I would say tolerance to homework too, tolerance to engage in a conversation for too long. And not everybody's affected the same way. That's the other thing that I want to say. We are in these studies, we're looking at the most severely affected because those are the ones that come to medical attention and start getting diagnosed. There is probably a lot of people with milder disease that do not suffer a lot of these complications. But the brain, because it has time to adapt through this narrowing that is progressive, it will put mechanisms to control the blood flow to the critical necessity that the brain has. And some of them is just adjusting activity level. Some of them is, I have kids that are as young as 3 or 4 that ask their friends to put them down with the legs up when they're feeling something. And I don't know what they're feeling, but that sounds to me that they're having some sort of pre-syncopal event or TIA or something that they can sense they're not feeling well. So I think there's a lot of coping, learning, compensatory mechanisms because the disease is progressive, and that may be why we are not seeing strokes later on. The other reason I think has to do with this carotid that we were talking about and the number of vessels that narrow. And not every kid and everybody has the same track of progression. And the more narrowing you have, the more likely you are still to have strokes, mostly when you get provoked by a challenge of low blood pressure or low hydration or sedation. Sedation makes strokes happen because I told you that the blood flow is primarily driven by the electrical activity of the brain. And when I sedate someone under anesthesia, not taking a little pill, but under anesthesia, I suppress the electrical activity. So now no one is calling for the blood flow. So the best answer to this is likely we are learning, and kids also have a better ability to regulate their activity level and their kind of positions and stuff. And also as the vessel narrow, there may be mechanisms that the brain uses decreasing the complexity of a network. And we see a lot of cognitive and behavioral impairments, which may be the result of these kind of cutting notches on the network that are not necessarily going to be so much used to decrease the metabolic demand. So I'm saying an answer that is pretty wide, but I'm trying to put all the possible mechanisms why we are not seeing so many strokes. The first one is we do not have a large number of patients that are adults to know if they are suffering or not strokes. The second, the narrowing of the vessels gives time to compensatory mechanisms, including changes in activity. And the third, not everybody gets the same narrowing.
The next question that we have is asking about when TPA might be contraindicated, and they had heard from their neurologist that it would not be a great option.
So that's specifically to your case. So there's a lot of contraindications that are for everybody. So if you are in a blood thinner like Lovenox, oral anticoagulants, or Coumadin, you are not eligible for TPA because the risk of bleeding is too high. There are other contraindications, that is, if you have had bleeding for any reason or big surgery, so general surgery, in the last couple of months, you may not be eligible for TPA. And in ACTA2, if the stroke is happening when the vessels in your brain are very narrow, TPA would not help that much. And because there are some little vessels that we know are new and not well formed, increasing the risk of hemorrhage from the Moya Moya cohort, that will put people away from TPA. So it is a conversation to have almost in a yearly basis based on how the disease is and how the symptoms are evolving, if you could or not be a candidate for TPA. I have to say something. There is not just TPA. There is also catheters that can go in. Putting catheters through these vessels that have the risk of dissection is something that you will have very hard time to find someone that wants to take that risk. But not because they are evil. It's because they don't want to harm, and we first try not to harm. So catheter clot retrieval, as we call it, which is now done 24 hours since the onset of the symptoms or the last time that you were seen well, may not be an option, but not because of the specifics of the brain stroke, but because of the vasculature that they have to go through to get to the brain. And TPA may or may not be an option if the stroke etiology is thought to be the narrowing of the vessel itself, because we don't believe that smooth muscle cells that grew into the vessel are going to be treated by TPA. No, we only treat that mesh that I show you of fibrin. So if the vessel is getting narrower and it clotted, or it got narrow to the point that it occluded, it's not going to be necessarily responding to TPA. And the only thing you increase is the risk of bleeding in that area that had the stroke. So time is one of them, anatomy, and then the anatomy of your vessels, not just in the brain, are going to be important.
Thank you. Okay, so our next question is, and I'm sorry if I mispronounce this, but it's from Eunice Perez from Miami. Do you want to unmute yourself and ask your question, or do you want me to ask it?
Hi, yes. My question is, my daughter also has Chiari-1 with syringomyelia. I don't know if that's pronounced properly or not, but I'm just curious if you have seen it in any other kids, or it's just an extra, as I call it.
So I have to say, depends on the how low the tonsils go. Chiari is a very diffuse term to say that the cerebellum tonsils, the part of the cerebellum, goes down next to the spinal cord, the medulla, in the back of the head, and it's a very common variation of anatomy, basically. And I would have to say, Arne, do you have a recollection? I do think I have one patient that I have been consulting with neurosurgery to time the scans and stuff like that, but it's never been something that we consider has been giving symptoms. And symptoms of Chiari are headaches that get worse when you're lying down, so you are in the middle of sleep and wake up with a headache, or difficulty with swallowing, and those kind of things. We have not seen, or at least we're not aware of, anybody getting Chiari, getting symptomatic, and needing to have anything done for that. And in terms of trouble with the vessels and the ACTA2, I would probably say it's pretty much not a problem. We do know that the brain reshapes because the vessels are so stiff, or they're so hypoplastic, we don't know it yet, and changes the shape. Chiari is not one of those that we've been seeing recurrently. I don't know, Arne, you have a recollection of seeing Chiaris on this cohort?
No, I agree. I think this is maybe an addition, like a chance thing.
Yeah, like an association, but not necessarily that has to do anything with the gene. And if it's not causing symptoms, we usually don't do anything about them, just in general.
Mm-hmm. Thank you.
Okay, great. So the next question we have is from Jay Biblau. I'm not sure if you want to unmute yourself and ask your question.
No, thank you. Dr. Musolino answered it already. Thank you.
Great. Okay, the next one is from Lauren Dayan. Do you want to unmute yourself, or I can just ask the question?
I could unmute myself. Just there I am. Hi, Doc. How are you?
Hi. How are you?
Long time no see. So I was just wondering if there have been any studies with the cord blood to help bring back some of the brain damage to the patients.
And that's, you're saying after a stroke, no? So when there is
yes.
white matter or a stroke, yes. So there are multiple, so there are clinical trials ongoing right now with the stem cells for patients that have had a stroke. We're talking about adults, a stroke that is not ACTA2. And stem cells that are a particular type is not cord stem cells, but one of the studies takes them from the cord, moves them to something specific that we think is more helpful to the brain. And they're being infused. Some of the trials is through the vein. This is in clinicaltrials.gov. If you want to know there is a study or something, clinicaltrials.gov, and you go to the search, put your keywords, and you can see if there is anything going on. These ones, we have one through the vein and one that are directly injected where the stroke happened. But they're not done in acute, they're done chronically after at least, most of them, 4 or 6 weeks, and the majority 6 months after the stroke has occurred. And the idea, and not in ACTA2, and I'm gonna say why it's relevant to put this separation, is that these cells that are more multipotent, it's not that they're gonna come and make neurons happen or myelin happening again, but they're going to provide trophic factors, the good food for those that are in the brain that can regenerate. And we all have a regenerative capacity in our brain all through life, the highest when we're babies, the lowest when we are 90. But their regenerative capacity can be called in, and that's what these therapies are trying to do. I do have to say there is an alternative market you can find of all kinds of stuff done with cord blood that is not being studied with clinical trials. A lot of them come from some Asian countries. Be careful and run it by your doc and ask them to give you all the data. So where are the papers where you guys learn, and what are the outcomes? Because it has to be something that has been reviewed by other people that have expertise. That's what we do when we publish like this. So we put ourselves under the scope and the critique and the rigor of the experts across the world. A lot of these private clinics have not done that work, and it might have to do, and I don't know it because they haven't done it, with not having really that great of outcomes if they do it systematically and if they look at every patient they've been treated. But I do want to say that stem cell therapy for neuroprotection and recovery in stroke is ongoing at the moment. In adults, not with ACTA2. My other concern, which could be for ACTA2, is anything that comes to your body that could cause an immunological response, like meaning because it's not yours, could have the possibility of releasing cytokines. Cytokines are these molecules the immune system uses to communicate to each other. And cytokines are the ones that give you fever and put you red. And the red is vasodilatation. Cytokines tend to be, when there is inflammation, vasodilatory. So one of the events that can happen whenever that person is exposed to cells or antibodies or anything that are foreign to them is that there is a large response immunologically, which can happen to any of us, not only people with ACTA2, but in an ACTA2 person that cannot squeeze the vessels, that could be a catastrophic hypotensive event. So it goes from a little bit of fever to I had a stroke. So there's that fault. And the other one is, we do know, and this in another disease that causes smooth muscle disease in the lungs, there's been recently work on mesenchymal stem cells infused in the blood to reconstitute the lungs. So to try to repair the lungs after injury or in babies that are still ventilator dependent. We've been looking into this with Dr. Kinan, and the stop that we are finding when we talk to the FDA and can we do it as a compassionate use is, and also among ourselves, is what is going to happen with the vascular system? If we're dealing with a very tricky disease that can lead to stroke if you challenge too much the vascular system. And that's why, if you imagine, like a beta blocker, which is a medication that a lot of people are put on for blood pressure and for other reasons, can cause strokes because the heart rate cannot increase and they might not be able to compensate when they need it, changing in positions. If that is happening with a medication that is so safe, what could happen with these other more experimental therapies is very difficult. So before we go there, we probably are going to have to learn a lot about what is it specifically and what are the expectations of side effects to see if the risk is justified. And also, what is the benefit it's supposed to provide, no?
Right, so
yeah.
No, so I'm saying, like, I wouldn't want to go onto a website and just pick out clinical trials from anywhere. I wouldn't feel comfortable, of course. And you being Rini's doctor, I would feel more comfortable. I'm wondering if you and the team are working on, with certain people to bring these.
And Dr. Milowicz is also working on developing therapies for the disease and trying to be very mindful of the risk that we're going to put kids and adults to. But also, if there is anything, and also you guys could always poke us because we are in fields, no? So I have a field, critical care, stroke, neurology, and it might be coming from a different field. And I will run it by the specialists and the experts in that field and put the ACTA2 knowledge. So it's not a bad idea to bring, if you heard about something, just email me and I will be happy to run it. But if there is anything available, you guys are going to be the first ones to hear about through the way that you heard about this webinar, like social media, A2A, the other foundations in aortic disease, and from the different labs. When there is a particular study that we believe is safe and worth trying, that doesn't take away compassionate use. And that is something that you always have to talk to your team when someone is very ill, and the risk that you can take is much higher because there is so much to lose. Then there are medications and therapies that you could consider doing, and that's called compassionate use. And in fact, the medication that I was talking about, the mesenchymal stem cells for lung disease on this other genetic smooth muscle disease, was done as compassionate use. But then it was something learned, and then there is a study running out of Italy for this particular mutation, which is in laminin.
Okay.
So not the same one as ACTA2.
Okay. One more question I wanted to ask. What is your view on, being that my daughter is 16 and a half, her having the vaccine for the COVID?
So I ran this by Dr. Kinan, which is, he's probably one of the most experienced smooth muscle pulmonologists that I know. There might be more in the world, but this is the one that I work with. And he says the risk of having COVID and having disease from COVID, and the disease in COVID could be the cytokine that we were talking about, but also directly to the lungs. And you know, flu could be devastating for kids with ACTA2 or with patients with ACTA2. COVID could be even more devastating. So he takes the risk of vaccine as almost dismal in comparison with the risk of getting COVID. So we are recommending everybody to get vaccinated as the vaccine becomes available to your people, to your state, your hospital. And if anything, one thing that you could all do is pre-medicate with ibuprofen or with Tylenol, acetaminophen. Those things are very safe. We've not seen side effects from kids that take them in more regular basis. And what they do is decrease that cytokine kind of, you know, when you get the vaccine, you can get a fever, you can get chills, you can get red,
yes,
you can feel like a flu. So you can minimize those symptoms. We have already very few patients that have gotten with ACTA2 Arg179. And so far, nothing that we have to report. So everybody gets sore muscle and fevers and chills, but it's not something that has caused complications, severe complications like stroke or low blood pressure or anything that we needed to admit the patient for.
Thank you so much. Your presentation was spectacular. I really appreciate it. Thank you.
Thank you, Laura.
Okay, so I think we have 2 more questions. So the next one is from Georgia Koltsida.
Hi, all the way from Greece.
Hi, how are you?
How are you? How are you again? I mean, it's probably a question for Dr. Kinan, but I don't know if you can answer that. How do the alveolar changes in these children like evolve over time? Like, have you seen changes in their chest x-rays or CT scans? And our patient in Greece was placed on diuretics from the cardiology team now for pulmonary hypertension, which, as you mentioned, is not an actual problem of the pulmonary arteries or pulmonary veins. And now we're kind of weaning her off diuretics, and they were like, no, from cardiac standpoint, she's well. So the diuretics are for the lungs now and not for the heart. So I want to wean her off diuretics. I don't see any point of her using diuretics. I don't know, what's your opinion on that?
I wear my critical care hat, and I would say probably not doing anything so helpful at the moment. We use diuretics when we need to ventilate the lungs and there is extra fluid because the blood pressure on the heart and the pulmonary resistances are not allowing us in critical care with these kids. But I would say there is maturation of the lungs is still happening. We see it, most of the kids that we've been following, even those that have been long-term ventilated as infants, develop lungs big enough and well enough perfused that they can wean off oxygen. There is the setback of injury that can happen with infections, with a pneumonia, with a flu. And we have seen patients that have pneumothoraces and that the lungs do not recover the normal anatomy. And some of them go back to be oxygen dependent or ventilator dependent later in life, in teenage years, most of them. So that I think in terms of the natural history of the lungs is to be told. We in fact need people like you that help us systematically now. What we did with the brain. We have a lot of the data from these patients, and it will be awesome to go through the findings that are there. To say, well, these are the events that we're seeing, these are the maturation, the volumes that we see, and what are their oxygenation levels. And in fact, I take that lead to say that we're going to be sending a small quality of life survey to families to start understanding these things, and then get the medical records on top of that to correlate it with what has happened. So maturation of lungs, Dr. Kinan, as you know, puts everybody on vitamin A.
Yeah, too. Yeah.
Good dose.
But since it's a problem of smooth muscles, and that can create like VQ mismatch, probably with any like stress.
Yeah.
But I don't see how that will be kind of fixed over time. Like it remain like the smooth muscles will remain like problematic, or they, they function well. So
Absolutely possible that the smooth muscle does not respond the same way to the vitamin A. We take it the way that we think about it, and he could elaborate about this a lot more. Maturation of the smooth muscle cells pushes them. So to proliferate, you will have to differentiate and go back in kind of your phenotype. The vitamin A is pushing them to be more differentiated, which pushes them to do a little bit more of the cytoskeletal proteins, which are suppressed from what we see in cells from the patients. So the cytoskeletal other genes, not only acting, are being kind of put down in a break. There is a paper by Dr. Lindsay in Nature Communications last year or the year before that shows a little bit of the mechanisms at play when this ACTA2 Arg179 protein is floating around. So what we think the vitamin A is doing is pushing differentiation, improving cytoskeletal function, the same way that the angiotensin axis does, and that's the rationale for the losartan low dose, and when the patient is not hypotensive and can tolerate it. There's a lot of reasons why you may not be on losartan, but this is trying to work on things that we see. This is not based on evidence-based, as you know. Like the vitamin A, we know differentiates the lungs. We know there is under-septation of the alveoli in ACTA2 lungs from the biopsies of the few patients that were done. And we have, I think I shared with you one of the pictures from the autopsies. It's a published paper. So the idea is if you push them to have a more differentiated phenotype, they may be able to have other proteins in the cytoskeleton doing part of the migratory to increase the growth and the septation. This is all theoretical, but that's the underlying kind of mechanism. And then avoiding oxidative stress whenever possible, and when someone is sick, may be another possibility for the lungs. And that's also been done in the mouse model that is not perfect right now because it's not the one with the Arg179H. So what has been published so far, and some of the antioxidants seem to improve significantly the function of the smooth muscle cells. So things that are done, we don't believe have a lot of risk because they've been using kids. They are FDA approved and they are tolerated. So each kid, we have to see if they tolerate it. We are trying to apply to them. Ideally, you want a clinical trial and do it very systematically, and you do it in some patients, you don't do it in other patients, and you check the CT scans of the lungs and see the development. We are not there yet because the disease is pretty rare and we are pretty much dealing on one at a time. But we are preparing for prospective studies to be able to answer some of these questions. But it will be really, really, really cool if someone takes the lead and looks at lung disease. And in fact, we can team up. There's a couple of people also that have been connecting with Dr. Kinan. So I'm almost putting the ball on your park again. Yeah.
Thank you, Dr. Musolino. Thank you for your impact all over across the world, and like to patients and doctors like me. Thank you so much.
No, thank you guys for including us in learning about the disease. We're doing this together. That's what I say to everybody. Thank you.
Great. Okay, so our next question is from Wendy Cummings.
Hi, Doc. How are you?
Hi, how are you doing?
Good, good. So I actually had a couple of questions based off of some of the other questions that was asked and then my original question. For You mentioned vitamin K.
Vitamin
I think
A.
Sorry, A.
Yeah.
Okay, then maybe I'm confusing, because I remember I had mentioned it to our neurologist down here, and she wasn't sure that vitamin A would be a good option to give Faith. But I
Okay,
can't.
so I will say one very quick thing. We can connect with Dr. Kinan, and each specific case can be discussed, like with their local physicians, basically, and see what they see, what they don't see, and what stage. One thing I learned is that the lungs develop all the way up to 12, 14 years of age. So if you're older than that, vitamin A may not make any difference, because it's to promote lung development that we're doing it. If your lungs are already done, we do not see necessarily the benefit. So that is one. It doesn't apply to faith. But they might not be seen as rational. And you just heard another doctor that it was like, well, but I still think the smooth muscle is dysfunctional. So I would say it's going to be a judgment call. It's not a recommendation that we can do as avoid dehydration. Definitely is one that we believe very strong about it. And we had data from the Moya Moya. But in this case, I would say first, I would love to have more explanation from Dr. Kinan, and I will make sure that we include this in the recommendations paper, so each physician and each family can see the rationale and see if the rationale applies to your case. But there is very little downside to putting the vitamin A. The only downside is if the kid has a G-tube or something, sometimes they vomit or they have residuals when you put vitamins, because it upsets the stomach, and you have to see with the tolerance that they have in the gut. But that will be my. And vitamin K, definitely, if there is no deficiency, there is no reason to do extra. And vitamin K we use when you are, some of the anticoagulants tackle vitamin K clotting factors. So if you're an anticoagulant, you don't want to take vitamin K because we're kind of antagonizing your anticoagulant. So vitamin K is a total different thing, and we only treat if deficient, which is very uncommon. It's a pretty abundant vitamin in many sources of food that we have. Vitamin C and vitamin D, antioxidants, I would definitely ask D to be checked to make sure, for those of you that live in latitudes where there's little sun, definitely do it, because a lot of people, more than 30% of the population, is vitamin D deficient. And it's an anti-inflammatory vitamin. And we want to be anti-inflammatory always for ACTA2, just to prevent, when there is injury, to be causing hypotension and more injury in these repair mechanisms that are impaired. So vitamin D, I checked on everybody at least once a year, and then I supplement with the over-the-counter or with a prescription. Vitamin C is an antioxidant. It's pretty safe to do it too if you are willing to do it, or just a lot of lemon and orange can do also the vitamin C supplementation. You don't have to buy it. Vitamin E, I contraindicate. And the reason is what comes from the hemorrhagic stroke data. Vitamin E, Edward, is a vitamin that has been associated with an increased risk of bleeding. And I don't see a benefit, even though it's an antioxidant, when there is a possibility of a risk. And in kids, it's been contraindicated by the American Academy of Pediatrics. So I would not necessarily want anybody to get E extra than the dietary recommended dose, no? So all the multivitamins that kids take on multivitamins are fine. What I'm talking about is going higher on the dose, which some people do by taking like capsules or granules or things like that. E is an associated risk of hemorrhagic stroke. And for just that reason, and because it affects the extracellular matrix, I will maybe stay away. I'm not saying it's not beneficiary in ACTA2, but we don't know that. And because we don't know it, I would not take the risk. I don't know a benefit, so I would not take the risk
Right.
that could happen.
Right. And then another question was, and I don't know if this is something that, I have two more. If this is something that you can answer, if it's something that Dr. Keenan can answer. I believe in the group, one of the parents had mentioned vascular changes being seen on kids who were wearing their masks for long periods of time.
Yes, we've had a conversation. Yes, yes. So, and we have seen, so a couple of things. COVID is worse than anything, okay? So getting COVID, not an option. So do anything you can to prevent getting exposed to COVID. And in this regard, that doesn't mean not going to school or anything, but just keeping the distance is the most important one. If the kid tolerates the mask, meaning there is no headaches, there is no tiredness, the kid is not more like not itself, so you can see it from how they behave. And taking breaks. And what I'm more concerned about the mask, to be honest, is that the drinking is a challenge already with anybody.
Right.
And if you put a mask, you go like half of what you drink, because
Right.
it's just having to go somewhere to do the taking the mask and drinking. So what I've been asking the schools, for example, is to have them separate enough that they can take regular breaks without having to go out of the classroom, for example. Some schools have that. Some schools have put shields in between kids that are high risk. At the same time, you have to try to not stigmatize the child, no? So it's always that balance. When you're wearing a mask, and if you guys have gone up the stairs with your mask, you feel kind of like short of breath. And it's because you're rebreathing part of the air that you're exhaling. So you're rebreathing your CO2. And when you rebreathe CO2, there may be a vascular response. In fact, there are people that are getting headaches because you're wearing a mask all day long. No, so for those of us that go on service and I'm 10 hours in the hospital and I have the big ones, I always get a headache. There's no way I don't get a headache. But that headache could be to the point of the vessels narrowing enough that there are teeny tiny ischemic areas, and we've seen 2 cases doing that. I'm not blaming it on the mask. I'm blaming it on the fact that maybe there is decreased hydration, there is a migraine being triggered, and maybe there is rebreathing of air. But it's still, I would pick the mask and those complications to COVID, guys. And I want to say that because there may be ways to not have to wear the mask all the time. You might have a shield that you can use, for example. And remember, when you do that, you're protecting the kid, but not the others, and it's not perfect. The best way to prevent COVID is distance and flow of air. So if you can get the school to open the windows, depending on where you are, that would be the best way. And this has been studied, and the CDC just published that if you open the windows and you have good flow of air, you decrease dramatically the transmission of COVID in the school classroom. So that would be my recommendation. Also, air is always great for just keeping kids awake and all of us functioning better.
Right. Okay, so it's not like an extended, like it's not just a one-time thing, or it's like an extended period of time kind of thing.
We don't know. I don't know it for sure. What I would say is that whenever the kid is wearing a mask, or anybody is an adult too, just try to be mindful about your hydration, so how you drink. And if you're not drinking by mouth and you're doing it through the G tube and stuff like that, just keep the routine going. And then the other one is sense yourself or check on the kid, and you can ask the teachers, like, are you feeling tired? Do you see well? Is there anything blurry? These are classic signs of someone kind of getting a little bit lightheaded. And then, do you have a headache? And if you have a headache, you have to take a break. Just go out, take the mask out, and maybe sit down, walk around. Whatever the kid feels like doing, they should allow the kid to do.
Okay.
That would be, I would not say wear a letter saying I cannot wear a mask and go everywhere without a mask because you can't wear a mask because you got a medical. That is exposing them to COVID in a way that.
No, not at all. I just wanted to know if it was like, we're okay to wear it for 2 hours, but we're not okay to wear it for 6 hours, or if it was just.
Nobody should be wearing a mask more than 45 minutes at a time. That's yeah, just everybody should have a break. And I'm saying the break comes with the drinking, so great to have a moment to go out, take the mask, drink, come back, go to the bathroom. And also this is based on what is the performance of anyone doing a task. It's been studied multiple times that if you stay for too long doing something, you lose your productivity and your efficiency. So you take breaks, you do much better. And kids more than anyone. And I see with remote learning that there is no breaks, that the teachers have to finish sooner for the kid to go to the bathroom. So for you guys, I would say just put very clear to the school that this is part of the IEP. Right. Hydration, breaks, and allowing the kid to regulate their activity level is part of their IEP of 504. Like these are the terms, guys, for the internationals that we use, the plans, the educational plans. that we have in the school, like special considerations that we do for kids.
And then my last question was, there was also discussion in the group about possible CBD oil use. If there's any studies, because it's been shown, I guess, with some, obviously not ACTA2, as far as I know, but it does like reduce inflammation in the lungs, or it reduces lung damage and brain damage. Some things that could be beneficial for ACTA2 patients. Has there been any studies, anything?
And you're using the same concept that we're using for anything we do, which is like, could it be provide a benefit? CBT oil in high doses, it also can increase, and mostly depending on what unsaturated and saturated oils you're getting on that CBT, has been associated also with hemorrhagic stroke. I told you just now that we don't see hemorrhage in ACTA2. So can you be on a CBT supplement? Probably yes, and probably you derive the benefits of a better cholesterol exchange and anti-inflammatory kind of a profile. I would always err on the lower side of things and seeing kind of how the kid tolerates it, and not go high on the dose, and don't follow blogs that are super believers of something, because they usually tend to be a little more extreme with the doses. But this is what I can tell you. I don't have rude data, but for adults with no ACTA2, there has been an association with high dose CBT oil and an increased incidence of hemorrhagic stroke. So that was the other one that we use. Vitamin E, Edward, and CBT cautiously. So if you do it, just do it in the lower side, the lower doses. The vitamin E, I would say we have now recommendations against. So I would not do it. There's also cardiac events that are associated with vitamin E. So vitamin, no, CBT, you could try it, and I would just try to look to have your pediatrician guided of what they see and what they do with children that is well tolerated.
That's well, trying to find somebody who would actually monitor it is a challenge as well. So I wouldn't want to just give it and then cause something, because obviously we don't want to hurt our kids. So I would want somebody to monitor it, and I know how there's a difference in.
You can ask the dose and that they will use in your child with your weight, and you can go with half of it. And I would say I do know a lot of patients that are in CBT oil, and I haven't seen yet any events of bleeding anywhere in the body for that sake. So,
is there like a certain brand?
I have no idea, guys.
You have no idea? All right.
Sorry.
Throwing it out there. It's fine.
But nutraceuticals, knowledge is very low, very low, and it's a whole specialty. So it's not that it's over the counter and doesn't have an effect or a medication or a risk. Those things are studied. It's a good question to put out to. So a lot of people with mitochondrial disorders also are using these cocktails. So maybe though they have been acquiring more data, I will try to take a look into that and see if we can find a guidance. They at some point, the mitochondrial clinic did put a set of dosing for some supplements, just ranges of what thought to be safe. And that was based on the discussions with the FDA. So it was a working group. This is like 15 years ago for mitochondrial disorders. We could extrapolate from them, but are we doing the right thing? I have no idea. We tried to do what we think could have very little risk of harm.
Correct. And that's what we all want, I think.
Like with all, exactly. We are